Bismillah ar-Rahman ar-Rahim. It's a great honor for me to announce for another session in the Egyptian Indian online webinar and online course. We are approaching the end of this very fruitful course. We have been more than 5 months of continuous education between the Egyptian and the Indian side, and a great operation between two great countries with great history, Egypt and India. Many thanks to my dear friend, Dr. Sernivas Kamhamti from India, for being the moderator of the Indian side of this very fruitful webinar and very fruitful course, and for introducing to this course the very eminent Indian speakers from all subspecialties. It's a great honor for me to be with such great professors from India, our dear colleagues and dear friends from India. Many thanks, my dear friend, for giving me this opportunity. Thank you so much. Today we have a very fruitful webinar. We have 2 speakers from India. Professor Vivek Trikha from India will speak about combined pelvic acetabular injuries, the Indian experience. And from Egypt, he will join us from outside Egypt now. Professor Abdelhamid from Egypt will speak about acetabular fractures, evaluation and management. Our first speaker will be Professor Vivek, and Dr. Sernivas will be the moderator of this part of the webinar. Please, sir.
Thank you very much, sir. Good evening, everybody. Thank you very much, Professor Elashab, for the introduction. It has indeed been a real pleasure working with you over these 5 months. I would like to introduce, can you see the...
Yeah. Yes, so sir, we can see it.
To introduce the speaker today. It's Professor Vivek Trikha. He's a well-known trauma surgeon in India. He works as a professor at the Jai Prakash Narayan Apex Trauma Center, which is part of All India Institute of Medical Sciences in New Delhi. And he's been in medical training and more than 25 years experience from AIIMS itself. And he has been regional and national faculty of AWO, SICOT, Asia Pacific Orthopedic Association courses on orthopedic trauma. And he was former AWO research officer, AWO Trauma India. He has delivered more than 750 talks in various conferences and courses. And he's part of SICOT Education Committee member, academic cell in charge of IOA, and AO coach for faculty, and is published more than 150 PubMed index publications, and also holds a patent for pre-hospital immobilization device. And his special interests include pelvic acetabular surgery, complex intra-articular fractures, skeletal infections, trauma basic research, and trauma education. The topic for him today is combined pelvic acetabular injuries, Indian experience. Thank you very much, Professor Trikha, for accepting the invite. Over to you, sir. Thank you.
Thank you, Srinivas, and thank you, the Egyptian Professor Elashab and other people from there who have been kind enough for inviting us and having this wonderful collaboration between India and Egypt. I'll be speaking on a topic which is close to our hearts in developing world and pelvic acetabular surgery, which is the combined pelvic acetabular ring injuries, or CAPRI as we know it. Just before that, would just like to give a description about where I belong to. I belong to Delhi, which is the capital of India. And these are the things which if you come to India and Delhi specifically, you're going to see all these monuments, both historical and the new ones, which are having a huge impact for the tourists out here. If you look at the Delhi population with the capital region as such, it's 32.5 million people in the entire area, which is of Delhi capital territory. And that's what New Delhi offers to you if ever you are going to come to India and to New Delhi. This is the place where I work, which is All India Institute of Medical Sciences. It's the premium government medical college of India, government-owned hospital with 2,500 beds, more than 50 specialties, We operate now roughly 3,500 trauma cases every year. And overall, in all specialties, there are roughly 1,500 publications worldwide for medical literature from our same institute alone every year. This is the place where I work. This is the AIMS Trauma Center, a 250-bed hospital, where we are dealing with all sorts of trauma which come to Delhi, especially the major polytrauma situations being an Apex hospital. I'll start my talk on the pelviacetabular injury with no potential conflicts of this interest in this topic. With these learning objectives, that first we define what do we mean by combined injuries. We understand the salient features of these injuries and also try to find out and describe the various principles which are there to manage this injury through representative cases. First of all, let's understand how do we define, what do we mean by a pelviacetabular combined ring injury? There's no specific definition so as to say, but if you look at the literature, the only good definition which can be found and can be used as a generalized statement is a pelvic ring injury that requires surgical intervention which is independent and of its own as compared to an acetabular. That means both of them individually require intervention which is operated. So we do not include the undisplaced pubic ring injuries or pubic rami injuries as a combined injury. We are involving those fractures which are having an indication for surgery for the pelvis, as well as an indication for surgery for the acetabulum. It's not so rare if you really look at it, especially in the third world countries where we have a lot of high velocity injuries. It will be less if it is a low velocity or fragility fracture sort of a pelvis and acetabulum. But in third world countries where it's the high velocity injuries which predominate, it's not so rare. The literature is roughly 15% in the literature if you see the incidence. In Laternal's paper also, it is 151 cases out of 940. And in 2010, by Suzuki et al. Also, it's 102 patients out of 1,600 patients. So why are we specifically asking for a combined pelvic ring injury with the acetabulum? Is it any different than the regular pelvis or the acetabular injuries we deal with? Remember that even if we consider pelvis or acetabulum as such, the combined injuries have a higher injury severity. They have a higher transfusion requirements. Reported mortality is roughly 1.5 to 13%, which may not be there in acetabular fractures alone, or if they are in pelvis injuries, it may not be so high. And the fracture patterns also are slightly different. Previously, they were having a lateral compression of pelvis and transverse fractures. And now we see some other patterns which are becoming more and more common. One thing which we need to understand is that combined injuries, fixation of one injury can impact the injury or the fixation of the other part. And that's what it makes it different from a regular pelvic injury or an acetabular injury. We also need to understand that we need to correct the hemodynamic instability which happens in the pelvis and also aim for the anatomical congruity which is required in acetabular fractures. If you look at the various papers which have been there, most of them have been quite less and they have not yet specified what exactly and what are the definitions which they have taken for these injuries. They have usually and mostly the 401 cases of Ganslin has taken roughly 25% of them where the pelvis was undisplaced and they did not require any fixation. The management protocol, we need to understand that life-threatening injuries have to be prioritized and managed, and the definitive management will be decided based on the patient's physiology, resuscitation status, as well as the associated injuries. We try to do them as early as possible, and there are few fixation principles which are there. If you look at the world literature, we have some specific guidelines for an acetabular injury management and pelvic injuries algorithms. But for the combined injuries, there is not possible, and there is no literature to define and give us a specific algorithm. Maybe because they considered not many people have really looked into this sort of fracture pattern. And very few data, as I showed you, these were the major cases where majority of them were undisplaced fractures. What we need to understand is if we treat the individual injuries as an isolated fracture after resuscitating the patient properly, then maybe we can have a good or a nice treatment option which is available. So because in the literature there is not much evidence for managing these and guidelines, I'll just share my experience over the last so many years of 15, 20 years of managing these fractures and what I have learned through the various cases which I'll be showing you, and what are the principles which we normally tend to follow with different case scenarios. Normally, the sequence of fixation is said to be ideally proceed from posterior to anterior side of the pelvis and also from lateral to medial, that is from periphery towards the center. Why do we do so? Because fixation of the posterior helps us to provide a stable construct, whereas the fixation of acetabulum can proceed over that. That's the guideline or the principle number one. It's mostly said in the literature, and that's why it is the principle which everyone tends to follow in majority of these cases. Let me show you a few examples of that. This is a journalist who was operated in 2009. He had a combined pelvic and acetabular injury. If you look at the iliac oblique and the obturator oblique views of these patients, and the CT scans, you will find that there is a crescent fracture or a fracture dislocation of the right-sided of the sacroiliac joint, along with a pelviacetabular injury or an acetabular fracture as well. Based on the guideline which I just showed you, that is, we start from periphery towards the middle, and from posterior, we tend to fix the pelvis first posteriorly, so that our acetabular proximal fragment becomes stabilized, and then we fix the acetabular fractures and get the anatomical reduction. So how did we go about fixing this? We went about by a supine position. The pelvis was fixed first in an ilioinguinal approach, which was in the same approach, we could be fixing the anterior columns was also fixed. And that's what we were able to do with a lot of screws. If you can see, we fixed the SI joint first, which was having a fracture dislocation with screws and two plates perpendicular to each other. And then subsequently, the anterior columns were also fixed. This is his 8 years follow-up, which we have been able to find. And he fares quite well with this. When feasible, we try to use a single approach. Give simultaneous access to the pelvis and acetabular injuries, and it helps us to reduce both the injuries at the same time. The single approach will have less morbidity and soft tissue injuries as compared to using a dual approach. Now let's see another case, which is having a bilateral acetabulum with sacral disruptions. This is the CT scan, 3-dimensional, which tells you what is the impact of that injury. He has a bilateral acetabular fracture. As you can see, the right side is sort of an associated both column. Left side is a transverse fracture. Pelvis, there is a sacral fracture, Dennis type 2, which is widely displaced. And he also has an extraperitoneal bladder rupture. Now, if you want to reduce this sacral fracture following the same principle, you may not get an anatomical reduction. Hence, we thought and we went about managing the posterior pelvis first in a prone position, and then we went about fixing the acetabulum in supine. Hence, we used two different approaches for the pelvis and acetabulum. So first, we took him prone. We were able to reduce that fracture, get the compression in that widely displaced sacral fracture, put in some screws and a transiliac plating, and then subsequently turned the patient in the next sitting and went about fixing his acetabular fracture by an ilioinguinal approach. You see that we have not put in a bigger plate because there was an extraperitoneal bladder rupture, and when we were opening it up, there was a clear fluid which was coming. And for a chance of infection and a probability of infection, we just went about fixing the acetabulum which was required. This was his CT scan, which was done subsequently over a period of 2 to 3 years. And you can see that the pelvis has been anatomically reduced from that position, which is on the right side, then and complete anatomical reduction of the sacrum has been able to be achieved. However, 10 years later, this was done in 2012. Last year, he came to us with arthritis, with a small amount of maybe an infection which was there, which was taken care of, and then subsequently we went about and had to convert it into a total hip arthroplasty. So we need to understand that these fractures can have a high mortality initially and also a high rate of morbidity or failures which may arise, though in this case it arrived and happened after 10 years of fixation. Now, let me give you another example. In India, we do have morbidly obese patients with a BMI of 40 and another similar case where he had multiple multi-organ injuries. If you see the CT scan, again, it's the sacrum of the same side as the transverse fracture of the acetabulum on the right side, along with the symphysial diastasis. Now, you can obviously see this X-ray and understand that this is a very high velocity injury which we are dealing with. There's a lot of soft tissue damage as well. And if you look at the patient's body profile, he was around 140 kilos and 6 feet, or roughly 40 BMI, which was a huge issue for us. How to manage him was also an issue. And once we were able to diagnose his things, chances of infection, DVT also needs to be understood while managing them. So our plan again was the same, that first we will fix the pelvis based on the same guideline that pelvis posteriorly needs to be stabilized first, and then subsequently you can manage and fix the acetabulum, because otherwise both the fractures and the fragments of acetabulum will be rotating. And then we will fix the transverse fracture and the symphysial diastasis anteriorly. We were able to push him down and put him into prone position, which took quite an effort from us. And this was our first case where we had such a patient where we had to go so deep in, but we were able to reduce this fracture. As you see the gap which was there in the sacrum, we were able to reduce it. And once through the shank spins in the PSIS and the ball spikes, we were able to reduce and put in the screws for the sacral fracture. We first put in this iliosacral screws, 3 screws in S2 and S1, and also added a plate, a transiliac plating for it, because he was such a huge patient that we didn't want to leave any instability on the backside. And then put in some vac dressings. And this was the sacrum which was now managed. And now this X-ray looks manageable. Once you have stabilized posteriorly, now you can go anteriorly and fix the symphysis as well as the transverse case of acetabulum. And that's what we did. We went anteriorly and fixed it with the collinear clamp, reduced it. And since he was having an extraperitoneal bladder rupture, again, I not risked putting in a symphysial plate, rather put in an infix for him because he was an ideal candidate for that. And subsequently, we were able to reduce this fracture from this position to this position, which was near anatomical reduction of that patient. This is his 12 months follow-up. And what we learned from this case was that if posterior pelvis is impacting and influencing the reduction of acetabulum, we definitely need to reduce pelvis first. If it cannot be reduced from the same approach, as in this case, we use dual approaches, because ultimately our aim is to have anatomical reduction of the acetabular fracture. Now let's see another case. 40-year-old man referred after 2 weeks to us, having a similar SI joint dislocation along with a transverse or a fracture pattern, bicolumnar sort of a fracture pattern. If you see the CT scans, it is 2 weeks. The fragment has gone vertically higher up. And to fix the acetabulum anatomically, you need to reduce the pelvis first anatomically. If you are not able to reduce that, your acetabulum will never come back to congruency. It was 2 weeks old. The hip joint was higher up. The proximal fragment of the acetabulum was higher up. And we went about fixing it anteriorly, thinking that we will be able to reduce the SI joint back. However, in spite of using all our maneuvers after 15 days as well, we were just not able to get an anatomical reduction of the pelvis. And since the pelvis was directly associated with the acetabular fracture, the malreduction of pelvis was not allowing us to reduce the acetabulum, as well as you can see in the third CT where the screws have been put and there is a gap in the posterior column. Somehow we managed to fix this, but I was not so happy with my reduction. And this is what we were able to achieve. You can see the pelvis was not reduced completely. There were around 5 millimeters to 7 millimeters of displacement. And that was leading to a slight malreduction of the posterior column, which you see on the iliac view, as well as a slight malreduction of the acetabulum. This was his 1-year follow-up. He was a policeman, went back to his place, was able to squat and sit cross-legged, which was relatively the most important thing which we normally in Indian traditions need to do, sit on the floor. And luckily for me, he came 12 years back in the last year in COVID times. And this was his X-ray. And you can see that over a period of 12 years also, he has been able to do and follow the same things. You can see how those ligaments, the sacrospinous ligaments and other ligaments have calcified, how some new bone formation has happened, and pelvis also there is some anterior SI joint calcification. There is mild amount of arthritis now, but he's able to fulfill most of his activities. He still doesn't have that much amount of pain. So if you are fixing a pelvis ring properly, it is critical to obtain excellent reduction. If you do not do so, your acetabular reduction, which is so very important, may not be achieved, leading to some failures. Then comes this main argument that pelvis needs to be fixed first, the posteriorly. Is it always the pelvis first? Just show you a case of 17-year-old female who fell from height and from 2nd or 3rd floor and was hypotensive, having a pelvic binder. We have to have hemodynamic stability for her. And you can see those binders with the towel clips put onto her. And this was her CT scans. If you see the CT scan, you will find that there is a fracture of the sacrum at the Dennis-Stute level. And the acetabulum has totally gone inside. Again, a very high velocity injury. She has these many combined injuries, low associated both column, iliac wings, dome fragment is separate, pelvic ring injury is also there, and sacral fractures. Going from the same guideline of following the pelvis first and then the acetabulum here may not give us the right reduction, because acetabulum has hinged inside and not allowing the pelvis to reduce. Hence, in such a case, you need to reduce the acetabulum first, because after reduction of acetabulum, only your pelvis, which had opened up, will go back and will get reduced. And that's what we did here, where the acetabulum was fixed first rather than the pelvis, because as soon as we reduce the acetabulum, pelvis will automatically reduce. And that's what we were able to achieve. We fixed posteriorly first the acetabulum region, both the wall and the dome part. Automatically, our SI joint, which had opened up, got reduced because it was hinged inside by a centrally dislocated subluxed acetabulum. And then we went about again anteriorly and fixing both the anterior and posterior injuries of this girl. This is her 6 months follow-up, 18 months follow-up, and you can see that she is able to walk around completely normally. This is the COVID times when she had sent us this in the 2020. And then now she just came last month to us, where you can see that still she is able to sit cross-legged, squat, and her acetabulum shows adequate joint space with good amount of reduction and congruity which has been achieved. Similar case where the hip has gone in first with a mild amount of pelvis fracture, where there is some moral level lesion also which needs to be debrided. And hence here again, we fix the acetabulum first, because if we do not fix the acetabulum first, the hip joint is going to deteriorate, go into arthritis. And then subsequently, when the wounds became okay, we went about fixing his pelvis again. So the next principle is, if you are not able to get the posterior pelvis injury reduction, which is not possible, then, and the fixation or reduction of pelvis is dependent upon acetabular reduction, then you might fix the acetabulum first anatomically, and then subsequently go for pelvis. And this requires a very careful observation of the pelvis as well as the CT scan to understand the picture of these cases very well. Finally, one of few cases where the pelviacetabular fractures of 24-year-old male had a huge moral level lesion. As I said, it's a very high velocity injury. So you can sometimes have a lot of soft tissue problem. You can see the swelling going right up to the scapula. And hence with this sort of a fracture which he was having, we fixed the soft tissue did not allow us to go posteriorly. We went anteriorly, fixed his SI joint and the pelvis, but we were not able to go posteriorly through Cocker-Langenbeck incision for this sort of an acetabular fracture. By the time it got healed, we were just able to fix the pelvis, and we had to leave the acetabulum as it is because it took around 4 weeks to 6 weeks for the soft tissues to heal where the incision was to be made for Cocker-Langenbeck. By the time the wound healed, this is the wound healing. This is his 9 years follow-up. You can see since the roof arc of those transverse fragment was more than 45 to 50 degrees, conservatively the dome was intact, the patient still managed to have good functional outcomes. And this is his range of motions at the end of 9 years. So remember that many a times you would like to do many things, but the soft tissue condition will be the one which will dictate the approach or sequence for you. At some times, you will have to accept what is available and may have to fix only what is practical and feasible, especially when the patients in our world type countries comes delayed or with a lot of soft tissues to us. Treat each injury as per isolated fracture. If any fracture pattern can be treated conservatively based on roof arcs, acetabulum, sometimes you might have to do that. Whatever I have shown you can and sometimes needs to be put into practice when you have such a severe case which comes to you, which is having, you can see he is having an L3 burst fracture, sacrospinous spinopelvic dissociation with S2 fracture dislocation, an acetabular fracture, and a femur fracture. You have everything which can have broken. You can have a combined pelvis, spine, acetabulum, and femur fracture. And this happens in our world countries. He fell from a height of around 3rd floor or 4th floor. You can see the bilateral sacrum fracture, how bad it is, along with the acetabulum which was there. So you have a spine fracture, spinopelvic dissociation, acetabular fracture, and a comminuted subtrochanteric fracture as well. And being in a trauma center, you need to deal with this So we fixed the spine first with the hip in external fixator with reduction of the hip. And subsequently, it was because reduction of spine was going to reduce the spinopelvic dissociation. Spinopelvic dissociation was going to reduce the acetabulum. And once the acetabulum is reduced, the subtrochanteric would have been easier for us. So a lot of things were dependent on each other. And we had to do a spinopelvic fixation first from L3 for this position. We fixed the acetabulum, and then subsequently we fixed his subtrochanteric fracture also. And you can see this is after around 6 months where a lot of callus on the femur has started forming. So I have shown you a lot of cases, complex cases, all because combined pelviacetabular ring injuries are not where the acetabulum or the pelvis is undisplaced. But both of them are so widely displaced that both of them require fixation in their own categories as well. And hence, it is a very, very high velocity injury, which happens when it is a combined pelviacetabular ring injury. Our aim should be to achieve anatomical reduction of both the acetabulum and the pelvis ring. Remember, patient's outcomes is first dependent on the mortality, which you can prevent by managing his pelvic injuries. And his morbidity levels can be managed by the accurate reduction of the acetabular component, which is so very important. Once you are looking purely for the morbidity part, it's 5 millimeters of displacement in the posterior pelvis can be accepted in a widely displaced fracture. But remember that in acetabulum, less than 2 millimeters of displacement is only acceptable. If it is more than 2 millimeters, it will fail. And in spite of your best efforts, you can see that around 10 years, 12 years follow-up, I have shown you, they still will go into arthritis many a times if your reduction is not so accurate. After so many cases, this is the take home in our Indian experience, I would say, that combined pelviacetabular ring injuries are a significant injury pattern. It has the resuscitative challenges of the pelvic injuries, which you need to follow and get back the patient's life first in the emergency department. And then subsequently, you also need to understand the reduction challenges, both for acetabulum and pelvis. Always evaluate the posterior pelvic elements in all acetabular fractures because your reduction of the acetabulum may be dependent and the final outcome may be dependent on what is lying behind in the pelvis in the posterior region. Proper sequencing sometimes will be required to optimize reduction and functional outcomes. I have shown you many cases where we did the pelvis first and then went to acetabulum, and few cases where the acetabulums were fixed first and then we went to pelvis. Sometimes through single approach, sometimes to dual approach. Remember, overall treatment strategy should integrate the independent assessments of both the pelvic ring and the acetabular fractures. Always strive for the best possible so that you can give the best possible functional outcome to the patient. Thank you very much for your patient hearing, and I'll be happy to answer any questions which are there, if any. Thank you.
Thank you so much, Professor Vivek, for this very illustrative presentation showing many complex cases that's properly and very well managed. Thank you so much, sir. Dr. Srinivas, you are the moderator of this session. First of all, I would like to welcome Professor Said Abdelhamid. Dr. Said, I know that you are now outside Egypt. Thank you for joining us, sir. You are muted, sir.
A great honor, and thanks for having me in this webinar. I am really honored to be a part of this one.
Thank you, sir. Dr. Srinivas, you are the moderator with Professor Vivek. Please, sir.
Yes, sir. Thank you. Thank you very much for the excellent talk on this important topic. I think we'll start off with the attendees' questions first. There are two questions. Question one is, how do you avoid sacral foramen while putting iliosacral screws across? You're muted, sir. Can you unmute yourself?
Yeah. So whenever you are putting in an iliosacral screw, you need to have, first of all, prerequisites of that will be have a very good image intensifier with you. It has to be a good one, which is having at least 9 inches of diameter, because otherwise you will not get a good profile. The maximum radiation or the radiation required or voltage required is for the pelvis and for the spine. So until unless you have a good image, you will not be able to see the foramina. The second thing is good preparation of his bowel so that there are no gas shadows which are there. If you are in the operation theater, what will happen is many a times you will find that every gas shadow appears as a neural foramina. So you need to make sure that you give charcoal, have a proper bowel preparation one day before, ensure that he has passed his stools, as well as there are no gas shadows by giving charcoal to him, or the charcoal tablets as we normally give. The second thing after this will be, you look in the outlet images of the fracture, the pelvis, to look properly at the rounded edges of the obturator foramen, of these sacral foramina. Once you are able to get the complete round sacral foramina, then only you are having a perfect outlet view. If you are not able to see the outlet view or the foramina of the fractured site, then sometimes it is preferable, the tip is, you look at the opposite side sacral foramina, and the same fracture line is going to, you just extend it straight line, and you will be knowing where exactly, extrapolating it and finding out where exactly your opposite side sacral foramina is going to remain once you have reduced it. After looking at the lateral view, the inlet and the outlet views, you will be mostly, and for the sacral foramina especially, you need to look at the outlet view properly to know that you are above it. The final tip will be, always remain at the eyebrow of your foramina, not on the lower aspect, because the nerve roots go down. So if you are on the top of your sacral foramina, you are going to avoid the nerve roots, just above it. So you go above the sacral foramina, not below them, because below, if you are there and you are just going to inside the foramina, you are much likely to damage the neural nerve root rather than when you are on the eyebrow of it.
The other question is, what are the criteria to choose between ilioinguinal and iliofemoral approaches while treating pelvic injuries?
Okay, so anterior injuries or anterior approaches are purely, I would say, if you really want to look at it, the mother approach is going to be the ilioinguinal. The classical gold standard is going to be the ilioinguinal. I always tell whosoever wants to learn in pelviacetabular surgery that you need to, even if you are going to do it, different approaches, do definitely learn the ilioinguinal, because that tells you the perfect anatomy of the entire hemipelvis. So if you want a complete access from the SI joint till the symphysial diastasis or the symphysial place, you have to go through an ilioinguinal if you want. Whereas if you want to just remain lateral to your iliopectineal fascia, then the so-called the modified iliofemoral, which is the Smith-Peterson with an ASIS osteotomy, that is the approach which we normally use for that. If you combine it with intrapelvic approach, it might give you a complete exposure right from symphysial till the SI joint. However, a single approach is the ilioinguinal, which is going to give you a complete exposure. So the other approaches like iliofemoral or intrapelvic approaches are the modifications of the gold standard, which is ilioinguinal. And depending upon the fracture pattern, you either choose an iliofemoral, which is lateral to the fascia, or if you want to go medial or towards the quadrilateral plate, you will go through intrapelvic approach, or you want to access the complete from SI joint till the symphysis, you might be tend to use the ilioinguinal, which is one approach which will give you the entire exposure.
And these combined pelviacetabular fractures are generally more high energy compared to isolated pelvic or isolated acetabular fractures. and they're more hemodynamically unstable, isn't it? So what damage control options do you have for these patients? And typically, how many days do you operate on these patients after injury?
Okay, so that's an important question, because unless the patient is saved in the emergency department, he's not going to come to your department or in the ward for getting these fixations done. So I always say everyone that the efficiency of a hospital depends on how you manage a pelvic injury, not the acetabular injury, the pelvic injury, because a pelvic injury tells you how your ED is functioning or emergency is functioning. And it involves the entire team effort from entire gamut of specialties. So what we do in our hospital is that we always are working in conjunction with our surgical team, general surgery trauma surgeons, who there and orthopedic surgeons form a team and work in polytrauma situations. So we need to look at his hemodynamic instability first. Following the ATLS principle, you give the binders, you put in the fluids, look at the ABCs, look at EFAST, and get his other organ injuries ruled out. And if it is a purely pelvic injury or a pelviacetabular injury for that matter, after the binder, we either go in for an embolization. If it is in the daytime, we do not have the embolization all the time available to us 24/7, because you really require an expert radiologist also who can do the embolization as fast as possible. Otherwise, we normally take him to the OR. If the patient is not getting stabilized within 30 minutes of his arrival inside our emergency department, he has to go somewhere, either to the emergency OR or to the radiology suite for getting his embolization or exploratory lab or looking for his preperitoneal packing, which we normally do. Majority of times we are believing in preperitoneal packing. And along with that, we just put in a fixator for the initial time to ward off the critical time. Once the patient gets stabilized, then subsequently, we are going to manage his other conditions and definitive fixations. The resuscitation screws are also put, but then you really require, the resuscitation screws are mostly for SI joint dislocations and vertical shear fractures, not that much for the sacral fracture, because there it might lead to some more complications which can be there. So hence, we normally take him for a preperitoneal packing with an external fixator, and then come back after 2 to 3 days, and then start managing him for his definitive fixation. But I would certainly say that preperitoneal packing and external fixator application and binder, along with hemodynamic control and resuscitative measures, which we use in the by ATLS principle, form the main basic principle of managing any pelvic injury in the emergency department.
Professor Elashab has a few questions. Please,
yes,
sir.
Please, sir. Professor Vivek, if you allow me, I have 2 questions, please, sir.
Sure.
First question, sir. I want you, sir, to mention to our dear attendees the criteria of implant selection when managing sacral fractures regarding the fracture geometry. How to choose between the sacral plating, the iliosacral screws, and the sacral rod.
Okay. So if we really look at the sacral fractures can be a B-type fractures. If we look at the pelvic injury as such, it can be a B-type or a C-type, which is a rotational injury or a rotational plus vertical shear injuries. And when they are involving the sacrum for B rotational injuries or for vertical shear, then based on that, you will be deciding your implants. The implant of choice ideally is a percutaneous iliosacral screw, which can be put, and you will be putting it as and when possible. As I said, there are some prerequisites for that you need to have good amount of good image intensifiers and good experience in putting that as well. Let's say that, and the patient comes early to you and you are able to reduce the fracture early. Otherwise, you need to open up, get your reduction, and then you put in the iliosacral screws. However, if you look at, there is an AO-spine classification also for the sacral fractures and the spinopelvic areas, which will decide based on the neurology and some modifications also, which tells us whether we can fix with the spine or go for a spinopelvic fixation, or we can just go an iliosacral. If somehow we are not able to get accurate reduction of for the iliosacral. Iliosacral screw requires, I would say, anatomical reduction first, because you are just putting it percutaneous. As per the paper by Mark Riley in 2007 or so in JOT, you will find that if your malreduction is around 5 millimeters, your area where you can put in the screw reduces by 35%. And if your malreduction is 1 centimeter, your area where you can put the screw reduces by nearly 50%. Hence, your reduction should be paramount, and then you can put in the iliosacral screw. Let's say that your reduction was not best because the patient came late or some other issues happened. At that time, a transiliac plating, which is done by putting in prone and giving the paraspinal incisions and putting in a plate after reduction, can also achieve nearly equal or slightly less amount of stability as compared to an iliosacral. So in Indian setting or in developing world where the patients come late to us, and accurate reduction sometimes is not possible after 10 days or 15 days, or the sacral foraminas are too comminuted, where you dare not put in, and if the compression happens, neurology of the patient might be disturbed. There, the transiliac plating can be put in isolation. As I showed you, sometimes I have put in iliosacral along with transiliac, because the iliosacral sometimes, because of the axial forces, might back out, and the transiliac gives us a better stability because it is holding the ilium together. Now let's come to the facet joints. If your L5-S1 facet joint is broken and the fracture is medial to it, or you have a spinopelvic dissociation for that matter, which is a flexion type, Roy-Camille, or an extension type, then you need to fix your pelvis to another stable fragment, which is the spine. And hence, you fix the L5 to the pelvis and ensure with a spinopelvic fixation. When it is a broadly vertical shear and mediolateral displacement, then you combine the spinopelvic fixation with iliosacral screws to get what is known as triangular osteosynthesis. So that's how you plan. Ideal way will be iliosacral. It is minimally invasive, less morbid, low soft tissue dissection, very less blood loss, good fixation. If not achievable, go for transiliac plating. If the spine is involved, or your bilateral sacrum is involved, or the L5 facet is having an issue, then you want to go for a spinopelvic fixation.
Excellent, sir. Thank you so much. My second question, sir, is regarding the highly comminuted acetabular fractures. Would you prefer to go to a trial of reconstruction or for primary hip arthroplasty? What do you prefer, sir?
Okay, so if we are talking in isolation for an acetabular fracture and not in a combined pelviacetabular injuries for that matter, so there are various things which we need to look for the best outcome for the patient, especially when the acetabular fractures are comminuted. Like the most important thing will be how the bone stock is there. If your bone stock is good or bad, that means that his bone is osteoporotic, or what sort of bone is there. Because high chances with marginal impaction that the failure will happen of the acetabular fractures. But in young patients, we definitely try to go in for fixation first, because as I've shown you that in spite of my not so good reduction, which I was not happy with in my patients in Indian setting, in our setting, are able to manage for at least easily for 10 to 15 years. So that gives us a much more time to go in for a hip replacement. But my indications for going in for a hip replacement will be a combined acetabulum with a femoral fracture of the neck, or femoral head fracture, which is fracture on both the sides of the hip joint. Elderly patient above 60, where the posterior wall is highly comminuted along with a transverse fracture where the cartilage damage is too severe. So, or in high elderly patients or very elderly patients having the classical osteoporotic sort of fractures, where the outcomes after fixation are not so good. So those are the fractures where we go in for an acute total hip replacement. Otherwise, in most of our young patients, we advise that it should be sent to a center where people are doing acetabular fractures regularly, and they are able to reduce the fracture as best as possible. And at least, if not completely ward off replacement, at least delay the onset of arthritis and get the replacement 10 to 15 years, postpone the replacement if possible for the patient.
Thank you so much, sir. Dr.
There's one question from the viewers, actually, attendees. One Dr. Mohammed asks, what is your experience in percutaneous screw fixation?
In the pelvis, or I think he's talking in the pelvis.
Probably pelvic acetabulum.
Yeah, so most of the screws which we show you, whenever you are putting in an iliosacral screw, that is done percutaneously. You give a stab incision and then you fix the iliosacral screws percutaneously. It's the reduction which can be open or which can be closed. Fixation with an iliosacral screw is all the time percutaneous. So if you are able to get the reduction without any opening, it will be purely percutaneous, I would say. But if you have to put in the screws and your reduction is not good, I will still say that reduction is paramount. Get an open reduction, as I do sometimes in a sacral fracture, especially if it is old and quite widely displaced or comminuted. And then we put in percutaneous iliosacral screws. The screws for pelvis are usually like that. Acetabular fractures, sometimes we put in column screws, which are percutaneous, but they are usually put for those cases alone, which are elderly and where you know that the outcome of your fixation is not going to be so good. Hence, you put in 2 column screws, one going posterior, one going anterior, a big 6.5 or 7.5 screw, so that you can hold the columns together and mobilize the patient early, minimally invasive or percutaneous, so that you do not damage the soft tissues also. And once the columns heal in whichever way, then subsequently you can go in and do a total hip replacement. So there is a role of putting in percutaneous screws in acetabulum, both the column screws in high elderly patients where you do not want to do acute total hip, but want to mobilize the patient without doing a reconstruction. So there you put in the column screws.
You talked about poor results in acetabular fractures in elderly osteoporotic bone. What come fractures?
I didn't get you, Srinivas. Your voice was not heard.
Sorry, I think the internet connection. Can you hear me?
Yes, now we can hear you.
Can you? Okay, you talked about poor results for acetabular fractures in osteoporotic bone in elderly. What about the results in combined pelvic-acetabular fractures, and what options are there for the osteoporotic bone?
Usually, when we are dealing with geriatric age group of patients, there the combined pelvic-acetabular fractures are a totally different entity, because they are not happening because of high velocity injuries. They are mostly happening because of fragility fractures. So you have acetabular fractures, which can be because of fall, having a posterior wall which is comminuted, or a medially displaced ACPHT or anterior column posterior hemitransverse type pattern with this dislocated. But your pelvis is invariably mildly displaced. It is just because of compression rather than an explosion, or like what we saw in our cases, which were high velocity young patients having a severe velocity of injury. So for most of the combined injuries which you see in an elderly, there your main aim remains how to fix the acetabulum if you can. Else, you go in and do an acute total hip replacement for that. And you put in the screws, which is iliosacral screws for the posterior. Nowadays, most of these patients require, and we normally put in transsacral screws, which are going from one side of the ilium to the opposite side in these cases, so that you are holding the entire posterior pelvis together by putting in transsacral screws. You put in 2 transsacral screws just to stabilize the pelvis. And your main focus is then dependent upon his acetabular fracture. And the aim with which we are going for the surgery is to mobilize him as early as possible. So you need to reduce his pain, get the fixation of the pelvis by percutaneous means, fix his acetabulum if possible, or go in for a replacement which is early so that the patient can be mobilized fast.
Thank you very much, Dr. Vivek. I think we don't have any more questions from the delegates. So if no more, we'll hand over to Professor Elashab for the rest of the talks.
Thank you so much, Dr. Srinivas. Many thanks to our dear professor, Professor Vivek Trikha, for this very interesting talk and very interesting presentation with complex cases and very good management of such complex and complicated cases. Thank you so much, sir. Now we will to the next part of the webinar. Our dear speaker from Egypt, Professor Said Abdelhamid, Professor and Head of Orthopedic Department, South Valley University, and one of the eminent surgeons in pelvic acetabular fractures in Egypt. Professor Said, I'm sorry because I know that you are outside Egypt, and I'm sorry for interrupting your vacation. I'm sorry, sir.
It's fine. Good evening, everyone. First of all, I'd like to express my deep thanks to Professor Mohammed Al-Ashhab. He's really doing endless effort in spreading knowledge between orthopedic surgeons in Egypt, at least for my knowledge. Special thanks to the Indian professors, Professor Srinivas, and special thanks to Dr. Vivek. He has enriched our knowledge by such complex cases, which is really challenging cases. And we learned a lot today about such complex cases. Congratulations, sir. Really nice presentation and very good outcome of your cases. From such complex cases to a very basic knowledge of acetabular fractures, I'll try to explain this. I'm not sure I can share my screen. How can you see, Professor?
Not yet, sir.
Not yet.
Sorry.
You open the presentation, sir?
Yes.
Press the green button down there for sharing your screen.
Okay.
Yes.
Could we
yes.
see it?
Yes, we can see it, sir.
Okay.
Full screen, sir, please.
Okay. Is it right?
Yes, sir.
Okay. Now, as I said, from such complex cases to basic knowledge of acetabular fractures, we are going to talk about acetabular fractures. In fact, in 2006, I have been to Japan, and their language is pictographic. And I find this letter of the Japanese language, which is, they call it kanji, and this letter actually represents a person, and they call it jin. And also this letter is like big. So if you combine both of them, you will get a big person, which means adult. You'll find that written on the sphygmomanometer as both the Chinese and the Japanese kanji are the same. Of course, our interest is not the Japanese language, but we are interested really in such person or such jin, which has two strokes, the long one, which is this, and the short one is this, And actually, this is a representation of the principle of two-column concept proposed by Judith and Letournel. In fact, Judith and Letournel proposed these two-column fractures, representing that the anterior column is a long one that can combined with the short posterior column in above the acetabulum, and they are holding the acetabulum, the acetabular articular fragment, and they meet together in a 60-degree angle. In fact, this is the anterior column representing the pubis, the anterior part of the acetabulum, and the anterior part of the iliac wing. And this is the short acetabular, the short posterior column, representing the ischiopubis, the ischium, and the posterior part of the column. And this is the acetabular dome, which is the superior weight-bearing portion of the acetabulum at the junction of the posterior and anterior columns. And of course, both of the anterior and posterior column, they share on the dome of the acetabulum, which is the weight-bearing part. Another very important part of the anatomy of the acetabulum is what's called the sciatic patris. This sciatic patris is very important because weight-bearing is transmitted from the sacroiliac joint to the acetabulum or to the two columns of the acetabulum through that sciatic patris. This sciatic patris also has an importance. We'll come to that later when there are what's called a specific type of two columns fractures that will be separated from both columns, and they no longer, the acetabular columns, they no longer has any connection to the axial skeleton. In fact, also this sciatic patris is a good place to anchor your screws when you are going to fix acetabular fractures. This is the acetabulum and the head of the femur. It looks like the stability is less until the anterior and posterior rim of the acetabulum representing the anterior and posterior wall. So now we have the anterior column, the posterior column, the anterior wall, and the posterior wall. How those fractures occur is usually acetabular fractures are associated with high energy trauma, secondary to either motor car accident, falling from height, or whatever the type of trauma. In fact, the geometry or the type of the fracture depends on the position of the femoral head in relation to the acetabulum at the time of injury, and the magnitude of force, and also the age of the patient. Young patients are different from those old fragile patients. In fact, Judith and Letournel, they classified the acetabular fractures into 5 elementary and 5 associated fractures. And the elementary fractures, actually, they have only one main fracture line. It's as simple as that. It's just posterior wall, posterior column, anterior wall, and anterior column, and also the transverse column. And actually, it looks like technically like a fracture through both columns, but they add that to the elementary type by virtue of purity, because it's a simple fracture. And the 5 associated types, which mean that there is more than one fracture line. There are 2 types of fracture at the same situation. Here is the posterior wall was the posterior column. Posterior wall was a transverse acetabular fracture. And this is the T-type fracture. And this is the anterior column with the posterior hemotransverse, what a long name. And finally, both column fracture, which is maybe the severest of them. Here is some clarification. Actually, this is the transverse fracture of the acetabulum, and this is the T-type fracture of the acetabulum, where the obturator foramen, the fracture is extending to the obturator foramen. And this is the case of anterior column with posterior hemotransverse, and we have to find the difference between both the T-type and the anterior column with posterior hemotransverse. This is also a low post-column fracture. You can see that the fracture line is above the acetabular fracture, and nothing of the articular part of the acetabulum is attached to the axial skeleton. While in the T-shaped fracture, there is part of the articular fragment still attached to the axial skeleton. In fact, those patients are usually associated with high energy trauma. That's why those patients have to assist very well according to the trauma protocol. We all know life before limb. Also, as a part of the local examination, we have to assess the neurovascular situation of this patient with a special care to the sciatic nerve, which is injured in up to 40% of posterior column fractures. Also, as Professor Vivek showed us, there's a lot of associated ipsilateral injuries like subtrochanteric fractures, femoral fractures, maybe patellar fractures, and other limb fractures, and also maybe a combined pelvic fractures. Soft tissue injuries are of paramount amount, because if you have bad soft tissue, that means you may not be able to operate, as showed by Dr. Vivek, that moral level situation. In fact, we come second to the radiological evaluation. We have X-ray and CT evaluation. In fact, most of people in the trauma units, first they have the AB view, and in fact, we can diagnose up to 90% of the acetabular fractures, and we can classify them depending only on the anteroposterior view of the trauma unit. And also there are two other views, which is the iliac and obturator oblique views. This is the AB radiographs where the pelvis, you can see it like that. And this is actually the iliopectineal line. And from the ischium to the pectineal, so the ischiopubic line. And this is the posterior wall, and this is the anterior wall. Let's see that on the radiograph. This is the iliopubic line. This is a ischiopectineal line, and you can see the anterior wall, the posterior wall here in the anteroposterior view. And if you have good quality X-ray, maybe it is enough to see the anterior wall, which is not the case unfortunately in most cases. But at least you can find the posterior wall and the anteroposterior view. This is the obturator oblique view, where you look at the pelvis from this side. You see the obturator foramen in front of you, and this is the iliopubic line, which represents the anterior column. And you can see also in your face the posterior wall. Here is the obturator or oblique view, where you can see the obturator foramen, and this is the anterior column, and this is the posterior wall. So in obturator view, we assess the anterior column and the posterior wall. You raise the injured side on a wedge of 45 degrees. In case you want to yes, this is in case of fracture, this is obturator foramen, and the fracture extending here, this is have a special importance. And here is the discontinuation of the anterior column, and here you can see the posterior wall fracture. The other view is the iliac view, where you see the posterior column and anterior wall. The wall is the reverse of the column in the radiological evaluation. In such a view, iliac oblique view, you elevate the uninjured side 45 degrees, and here you can depict the posterior column and the anterior wall. Again, you can assess the anterior wall through the iliac view. This is the X-ray anteroposterior view, iliac view, where you can assess the posterior column and the anterior wall, and obturator view, you can see the obturator foramen, where you can assess the anterior column and the posterior wall. In fact, obturator ring injuries are important, because if you have obturator ring disrupted, that means you have column fracture or T-shaped fracture. Also, if you have an iliac wing fracture, that means you have either anterior column fracture or both column fracture or anterior column and posterior hemitransverse. So depicting the X-rays are important, especially to the iliac wing, which you can see also in the iliac view, and the obturator foramen, which you can see on the obturator view. CT add a lot of information, and in simple, if you see the transverse line here, that means that this patient has column fracture. And if the fracture is vertical, the fracture line is vertical in the supratictal part of the acetabulum, so that you can expect transverse fracture. Actually, the coronal fracture line in the CT is for column fracture, C for column, C for coronal. And also the oblique lines can represent the fractures in either on the anterior or posterior walls. This is a wall fracture, and this is a column fracture, and this is a transverse fracture. Coronal is C4 column, C4 coronal. And actually, this is from Dr. Gansling, nice one. We have only 10 fractures. And if we look at the ilioischial line, it will be disrupted here. Disruption of this line means that we don't have a posterior wall fracture. The diagnosis will not be posterior wall, will not be anterior wall, will not be anterior column. So we can omit 3 of our choices. And then if we look at the iliopubic line, iliopectineal line, we will find it intact. So that means that there is no anterior column fracture. So we can omit the transverse fracture, the transverse was posterior wall, transverse only, anterior column was posterior hemitransverse, and both column fractures. Now we have only 2 choices. Either this is a posterior column in addition to posterior wall, or posterior column only. And if you depict this obturator view, you can see the posterior wall of the you can see the column and wall of the fracture. This is a nice way to find it. This is another X-ray. In fact, I will skip those slides because they are for training rather than for such kind of presentation. What's important also is the spear sign, which is the pathognomonic for post-column fractures. You can see it in the obturator view. Here is the spear sign, which represent the proximal part of the axial skeleton, which is no longer associated with an articular fragment of the acetabulum. Also, we'll skip those slides. Also, this is the seagull, which is a representation of the posterior wall fracture. In fact, for management of acetabular fractures, the initial management is very important. Life before limb, patient stabilization. You would have to go to the emergency room where the patient is evaluated and stabilized. The patient is usually placed in a skeletal traction. Sometimes if the fracture is stable and there is no dislocation and the situation is not so severe, we can avoid skeletal traction. But if we are planning to delay the surgery for some kind of patient stabilization, we may use skeletal traction. What is the goal of treatment of acetabular fracture? In fact, we have to go for anatomic restoration of the articular surface to prevent the post-traumatic arthritis. This is the main goal. Treatment depends on patient factors and fracture characteristics. Old patient is different from young patient. Fragile patient is different from that young patient. Different fracture patterns needs different methods of dealing. And now, if after the initial treatment of the patient, we have to have the decision to treat such kind of patient, either conservative or operative treatment. There is a rule for conservative or non-operative treatment in acetabular fractures? In fact, yes. If there is displacement less than 5 millimeters in the dome, or the articular step off is less than 2 millimeters, as Dr. Vivek said, provided that the maintenance of the femoral congruency, out of traction, absence of intra-articular osseous fragment. If the step off intra-articularly, and this is common actually for all intra-articular fractures, less than 2 millimeters, we can accept this because it will not lead to the post-traumatic arthritis. Also by Matta's roof of arc, it should be, in the three views, should be more than 45 degrees, which indicates fracture stability. The other option is the hip stability. If the fracture of the posterior wall is less than 50%, provided that it is stable, we may conserve it. And if it is more, we can do the stress test. If it is stable, we can still conserve such kind of patient. Secondary congruence is accepted as a conservative treatment, especially in elderly people. Now come to the timing. What is a suitable best time for operating on such kind of patients? Urgent upper reduction internal fixation actually is exceptional. And those are the situations when we are obliged to interfere or to do the operation in an urgent basis in case of there is sciatic nerve palsy after reduction. And in case of there is large fragment preventing reduction, especially as fracture dislocation, and associated pelvic ring dislocation, as Dr. Vivek said, maybe we can interfere as early as possible. And in the rare situation of open acetabular fractures, may be an indication for urgent internal fixation. In fact, the timing of surgery affects the anatomical reduction. You can see that delaying the patient more than 2 weeks you can achieve only accurate reduction in only half of the patient. 54% of the patient only we can achieve anatomical reduction if the patient presented or operated upon after 2 weeks. And actually, to the conclusion, surgery should be performed within 2 weeks of injury, and the ideal time after depicting the literature is from 2 to 5 days. Which approach we can use? Actually, proper preoperative classification of the fracture configuration is essential in selecting the approach, because you choose your approach according to the fracture configuration. Posterior fractures are approached posteriorly, anterior fractures is approached anteriorly, and sometimes you are in need to combined approaches. In fact, no single approach provides ideal exposure of all fracture types. Here we have those are the approaches, options present in operating on acetabulum. Coker-Langenbeck. I think Coker-Langenbeck is a working horse for the acetabular fractures, and of course it's best process access the posterior column, and usually we do it prone because it facilitates the reduction. And the ilioinguinal approach, best access to the anterior column and inner aspect of inguinate bone. And as Dr. Vivek said, it is the classical teaching and the gold standard in acetabular fractures. In fact, we shift to the intrapelvic approach, what's called the modified Stupa approach, and we can still use the iliac window of the ilioinguinal approach. Also the extended iliofemoral approach, I think best simultaneous access to both columns, but due to the high morbidity of such extensile approaches, I think they are no longer used. Especially those approaches are associated with high incidence of myositis ossificanis. Stupa approach or intrapelvic approach allows access to the medial wall of the acetabulum, quadrilateral surface, sacroiliac joint, and even you can manipulate the posterior column from the modified Stupa approach. And also, you can still reach the sacroiliac joint through the intra-pelvic approach. Here is the Coker-Langenbeck, which is really a very nice approach. And this is the working horse, I think. It can be used for treating the posterior wall fractures, posterior column fractures, posterior wall and posterior column fracture, transverse fractures, transverse with posterior wall, and some types of fractures. In fact, some doctors, they prefer to approach, for example, the transverse approach. They can approach it from the more displaced type. If it is more displaced anteriorly, they prefer to go anteriorly first, and then they can manipulate the fracture and just adding some fixation to the posterior column. This is the idea of approaching the fracture from the more displaced type. In fact, in the Coker-Langenbeck, we have to take care of two things. The first is the labrum, and second is the blood supply to the head of the femur. As you all know, the main blood supply of the femur is posteriorly from the ascending branch of the medial circumflex femoral artery. And actually, you can find this artery at the insertion of obturator externus muscle. We have to keep our dissection away from the blood supply to avoid the incidence of avascular necrosis of the head of the femur. In fact, I couldn't find access all my cases because unfortunately I'm outside because of misunderstanding about the date of the, I thought it's the 20th of October, not 6th of October. And in fact, I find those on my phone. This is a transverse fracture, severely displaced, as you can see, with maybe like a central dislocation of the hip in a 37 years old male. And here is how we did the operation. I usually use a small plate. We call it the reduction plate. Sometimes, especially in muscular people, using our instruments is really bulky and cannot give you the access to manipulate the fracture and put your plate after that. Then first, I just stabilize these two holes plate. And then I go to put my plate on the posterior column. And here is also, this patient also have a posterior wall fracture. And this is a 6 months follow-up of the patient. Here is the iliac view, and here is the obturator view. And patient is doing well. In fact, another case of also a transverse fracture. And I usually approach those fractures, as I said, posteriorly, and still I can use the reduction plate. And this is a follow-up of the case 2 months after the operation. In fact, I have this case like 3 years, but unfortunately I couldn't access the preoperative X-rays. And here is this patient have a transverse fracture on the right side and have sacroiliac joint disruption. And also she has anterior column fracture on the other side. She's a female, 20-something years. And this follow-up X-ray actually after 1 year of the operation. Through the modified Stuba approach or intrapelvic approach, we put this plate to fix the anterior part of the fracture. I use a posterior column. You can manipulate the posterior column from the intrapelvic approach and use that screw, which is the posterior column screw. And also you can use if you like, the second window of the first window of the ilioinguinal approach if you couldn't fix your plate or do the reduction the right way. This is a percutaneous iliosacral screw, anterior column plate, posterior column screw, and I use the anterior column screw for the other side. In fact, we can use percutaneous fixation in acetabular fractures, and we have some cases. If the displacement of the columns are not so severe, and also if you can, if you can do a small approach to reduce the fracture to help reducing the fracture and introduce your screw, I think it will work in a good way. Even in those young people, the outcome may be okay. And this is a iliac view of this side and obturator view of this side after 1 year. And this is a posterior column screw, and this is a iliosacral screw, and this is a column screw from the other side. This is also the obturator view of the other side, which is the iliac view of the injured side. Thank you very much. I hope I could do the job the right way.
Thank you so much, Professor Said Abdelhamid, for this very interesting presentation about the basic aspects of acetabular fractures, which is a very important item to understand the acetabular fractures. Many thanks to your presentation, sir. And I have many questions for you, sir. First question, how to differentiate radiologically? I have a presentation also on the fracture acetabulum, and it's very important to understand the geometry of the acetabulum so I can manage the fracture acetabulum. My first question, sir, to you is how to differentiate radiologically between the transverse, the T-shaped, and the bicolumn fracture of the acetabular fractures, and the importance of this differentiation for the way of management of different shapes of acetabular fracture.
Just a moment, please. I'm not sure I can see. I can hear you, but I cannot see. But anyway, differentiation between transverse fracture and T-shaped fracture
and bicolumn fracture.
And bicolumn fracture. In fact, the transverse fracture is through transverse line affecting both the anterior and posterior column. However, there is the upper part of the proximal part or part of the dome of the acetabulum is still attached to the axial skeleton. The T-shaped fracture is a transverse fracture with a vertical limb extending to the obturator foramen, separating the ilioischial and iliopubic part, or the inferior part of the acetabulum, so that you can have like 3 fragments, and the rotation of those fragments is really difficult to reduce. In case of both column fractures, the fracture line is above the articular fragment. So no longer any part of the articular fragment with acetabulum is no longer associated or with the axial part of the skeleton, or as I said, the sciatic patris is no longer the sciatic patris is no longer attached to the column.
Yes, sir. And the importance of differentiation between the importance in the management, in the way of management, sir, and the approach, sir.
In fact, each fracture of those has different approach and different method of fixation. Because if you have a transverse fracture, as I said, you can, most of the time, you can approach the transverse approach from the posterior approach, which is for me a bit easy and less morbid, I think, for you too. Post column fracture needs, for me, I usually use the intra pelvic approach, modified stopper, with the iliac window of the, if I need to address the iliac wing part, I use the iliac window of the ilioinguinal approach. T-shaped fracture is the most complex of them, and you may need to approach it from 2 different approaches.
Yeah. I ask you this question, sir, because it's very important to our dear attendees to understand the difference between each type of acetabular fracture and the importance of this differentiation for the way of management. My second question, sir, to you and to Professor Vivek, your experience regarding the percutaneous column acetabular screws.
Should I answer?
I want to you your experience, sir, and then Professor Vivek.
In fact, I have some experience of percutaneous screws. Unfortunately, I cannot see the. I can just hear you. I'm not sure. So anyway. Yes. In fact, I have some experience with percutaneous screws. As I said, with those patients of very limited displacement. I mean, the displacement of the fracture can be reduced to near the anatomical. I think those cases are not there is no too many cases of these cases, but there is. And if I find this case, I will do. Actually, in this case, I presented the other side of the acetabulum. The left acetabulum was mildly displaced. That's why I used a percutaneous screw of the other side.
Yeah, the same thing for me. As I said, my fixation methods will differ for a young patient and an elderly patient. For an elderly, the reason why we fix with percutaneous is going to be totally different, because we want to mobilize them early and we want to make sure that the bones heal whichever way, so that we have another option later. In young, so even with a mild displacement or some residual displacements, we can still fix in an elderly patient. However, in a young patient, as Professor Hamid was saying, if it is very mildly displaced or undisplaced, and for the early mobilization, which will be helpful, or I can, by minimal invasive way, I can reduce that fracture, and then you want to fix in the percutaneous screws, then most common screw which I will be putting will be the same screw as Professor was showing in his presentation, the last X-ray of that lady, is the anterior column screws which grow from the ilium towards the pubis. So that is the screw which we normally would be putting it for the anterior side. Posterior side, I normally am not putting in the retrograde screws which are there. I feel that it's not, if I really want to put in a percutaneous posterior column screw, I make just a stab incision around 1 centimeter or so from the iliac crest, put in my drill sleeve, and then under image, I will put in a posterior column screw for that. So those are my indications as well as the techniques of doing it. That's all.
Thank you, sir. My last question before I go to my dear friend, Dr. Sernivas. I want you, Professor Said and Professor Vivek, to enumerate to our dear attendees the principles of management of pelvic acetabular fractures in children. So the picture will be complete regarding the acetabular and pelvic fractures. Sir. Professor Said, please.
In fact, we deal with children or pediatric fractures as a small adult, which is not the fact. Actually, they are different. They are not young adult. I mean, they are different category, because the tolerance of deformity is still present. The remodeling is still present. And actually, the acetabulum is very thick and still add to the stability of those patients. In fact, I have some cases of pelvic fractures in children, and I use actually the iliosacral screws, as Professor said. Sometimes I used like a thick K-wire instead of screw. Unfortunately, maybe it looks like less stable, but they are not actually adult, as I said. Actually, I use also anterior fixation, external fixation. Maybe my youngest patient was 4 years. I used for her iliosacral screw and anterior fixation using supraacetabular fixation, and they do very well, actually. Still, we don't have a specific entity to deal with them. That's why we still deal with them as small adults, if this expression is true.
Yes, thank you, sir. Professor Vivek, please.
Yeah, if you look at the overall incidence of pelvic acetabular fractures in children, it is quite less. Number one, the reasons for that is because the bones are very pliable. It's mostly the ligamentous structures in the pelvis which are much more stabler than what the bone is. And hence, the bones normally have some green stick sort of a thing rather than actual fracture which happens in an adult. That's how they differ. The pelvic injuries, and they are really very high velocity injuries which happen, like a run over or a tire of the car goes over them or something like that, which usually causes such injuries. So most of them will be associated with soft tissue problems, which is usually there. The soft tissues are quite disturbed in them. As Professor Hamid was saying, the pelvic injuries are ones which are usually, first of all, we need to understand the radiology of the patient or a child, and then understand his displacements. The problem in pelvis in a child is that you will find a wide gap between the sacrum and the SI joint usually, because the cartilage is there and you are not having a good formation there. So many people assume it to be a pelvic injury, which it is not. So first, you need to examine under anesthesia whether there are real displacements which are happening or not. That is number one. Number two, as many of the sacroiliac joints which can get dislocated in children as well, vertical shears and such things can happen. So in those fractures, you will be putting in, I have put in 2 mm, 2.5 mm K wires as holding the SI joint for 3 to 4 weeks or 6 weeks. And then even I have removed them, because the children remodel and their union rate is very fast and they become sticky very fast. Sometimes we have put in 4 mm screws, partially threaded or cannulated screws or something like that, putting in small screws which are there. But a mild amount of 5 to 10 millimeters of displacements in the sacroiliac joint, which appears on an X-ray or radiology of a child, may not be a dislocation which we presume in an adult. So that's how the children will be different. Acetabular in the interior part also, symphysis also, it appears as if it's a long or a huge diastasis, but actually you will find that a lot of cartilage is there. So you need to really find out the pelvic injuries. If possible, get a CT scan, which may be a radiation part, but if you are really doubtful, or examine under anesthesia. That is a better way of looking at the instability of the pelvis, and you try to manage only the instabilities rather than fractures for that matter. Anteriorly, you can put in a tension band wire or an encircler sort of a wire, or sometimes a thick 5 ethibond also can help in holding the structures together for you, or as an external fixator, as Professor was saying, the supraacetabular. Acetabular fractures in children are quite rare. And what needs to be understood is they usually have some injuries at the triradiate ligament part where they are joining. And sometimes, in spite of looking at it and looking and following them up, you can have some growth disturbances sometimes, which is not under our control. Because sometimes it may have, just like in an epiphyseal area or the growth area, which happens, the physeal scars happen. Sometimes the triradiate unites faster in an acetabular fracture, but unfortunately, many a times we do not have much control in those situations. A high index of suspicion sometimes is required in an acetabular fracture if you feel. But normally in my hospital, we go examine under anesthesia, under image intensifier to look for instabilities. And instead of radiology, we rely more on instability under image for any intervention which we need to do, especially in children below 10 years of age.
Thank you, sir. Dr. Srinivas, please.
Thank you, sir. That was an excellent talk, Professor Abdelhamid. Thank you very much. I just wanted to ask both the speakers actually on the thromboprophylactic protocols. These are high-risk injuries. So when do you start your prophylaxis, and for how long do you give prophylaxis?
You mean antithrombotic?
Yes, sir.
Thrombotic medication?
Yes.
This is a very nice question. Actually, we are in a difficult situation, fearing of hemorrhage of the incidence of thromboembolic events. However, at the end of the day, we use the prophylactic antithrombotic. We usually use the NWACs, the oral anticoagulants. Actually, I use them for 5 weeks, starting from the second 12 hours after the operation. Sometimes there is some troubles, but anyway, you don't have options. To me, at least. You can hear Dr. Professor.
So we normally tend to give anti-DVT prophylaxis for that. We start preoperatively by putting them on aspirin. That is what is our normal way. And if he has much more, because if you look at those criteria of the patient and the FRAX criteria, pelviacetabular injury comes at a high risk category, along with hip fractures and all the comorbidities for the patient. So normally you need to give them some DVT, some prophylaxis, thrombolytic and things. So we normally put them on aspirin in our conditions. Post-operatively, we are on, let's say, or those stockinets which we are there, and the DVT pumps which are there with us. So these are the ones which we give, normally rely on physical DVT pumps or stockinets in the pre-operative time. And post-operatively, once we have operated, from the next day onwards, depending upon the risk profile of the patient, and sometimes the expense also, which economics also, which plays a role in our country. During the hospital stay, we tend to give them low molecular weight heparin if they are high prophylaxis or high risk patients. Otherwise, we put them like a comorbid or like a morbid obese patient, which I showed. Those guys were put on low molecular weight heparin straight away. Otherwise, all the patients go on aspirin, 150 milligram HS for the next 4 to 6 weeks. We try to mobilize them faster, and we make sure that the chemical prophylaxis is there post-operatively for 4 to 6 weeks for them. That's the thing. But in young patients, our main aim is to mobilize them as early as possible. And if they're having an acetabular fracture, within 2 days or so, we are making them weight-bearing, toe-touch weight-bearing with a walker, and make them walk around. So that as soon as they get back to their pre-injury status, at least for mobilization part, the chances of DVT and those things will go down definitely. But you need to take care of it. We have examples in our hospital, and especially in India, where many people think that DVT does not exist. There are very big papers which are there in India as well. And we have our own experiences where we had patients pre-operatively as well as post-operatively after 5 to 10 days, whom, because of the manipulation and the injuries, we could find when we had done CT angios that they had a huge DVTs or thrombus going from infrarenal region till the proximal veins and the thighs. So we had cases. So that's why we are slightly more, you can say, aggressive or try to give them thrombolytics.
Thank you. The other question is, generally the approach for these fractures is very difficult. And do you have to, do you have any indications for implant removals for these patients, especially for, if you have to do a total hip replacement? And how difficult or easy is the implant removal in such cases?
You need me to answer, or Professor Hamid is answering?
Both, please.
Okay. In fact, I removed a lot of. Of course, the incidence of post-traumatic arthrosis after acetabular fractures is not that rare. And the first injury, actually, even if you do the nice reduction and the stable fixation and everything, after sometimes you find the osteoarthritis of the patient. Sometimes there is hidden injuries, cartilage injuries. Sometimes there is femoral head injuries, which is hidden and you cannot really know at the time of the operation. 6 months later, 1 year later, the patient comes with osteoarthritis. In such case, if I approach the patient posterior and there is posterior implants, I do the ESR as a profile of ESR, CRP. If everything is okay, I proceed to total hip replacement from posterior approach. I do also the posterior approach. And if the implant is not interfering with the acetabulum, there is no need to remove. In some patients, if they have infection or so, I go and remove the implant first and wait for like 6 months after antibiotic treatment. And if the profile of those patients of ESR and CRP is reduced and the patient is ready to receive total hip replacement, I will do that in like the second stage as 2 stages. In fact, I use the intra-pelvic approach, so removing the anterior plate is really pain. And it's not that easy job. I'm not sure you want to do it. But if there is infection or it's mandatory, you have to do anyway. This is my opinion.
Yeah, I agree with him. I always say that putting it in is so difficult. What to say about the removal of it once the planes are also not visible. But yes, sometimes there are conditions where you need to remove them. Like I would say that for me, infection is one major thing where you need to remove them. And even if sometimes what happens is there is infection which you subsequently wanted to go in for a total hip as well. So you need to start with debridement and implant removal, and then only you can go for the stages of infection correction and then control and then going for replacement. So those are the cases where we had to remove it. Posterior ones are easier to remove and usually infection wise only, because otherwise if you are having an aseptic loosening or arthritis, then total hip with implant in situ is not a problem. You just remove those screws or any implant which is coming in your way. Otherwise, you do not remove all the implants of acetabulum. So for me, major indication is infection. Sometimes I do remove implants in cases of young females whom I'm treating for pelvic injuries and symphysial fixations, which I do. So I'm slightly more particular regarding removal of them. I tend to use fixation less in them anteriorly. If possible, I would avoid it. But if I have to fix them, I normally tend to remove them, especially if they are in reproductive and childbearing ages. So those are my indications of removal. Otherwise, normally. As he said, intrapelvic, I would dare not go in and think about the fibrosis, which I am going to see. Because sometimes when you go in for revision cases, which have to be fixed, which are failed revisions, like for symphysial fixations and the pelvic fixations which failed, and you have to go for just a symphysial plate removal, you will see how much fibrosis happens with the rectus and the bladder. You just cannot differentiate between them. So sometimes it is difficult to do that. And you are more prone to bladder injuries and vascular injuries in those cases if you want to do the implant removal.
It's interesting you said about reproductive age group females. What about pregnancy? If they have a malunion of the pelvis, or do the implants cause any problems during pregnancy?
Normally, no. But that can be an excuse for anybody. So that's why I tend to remove them. Because actually the uterus is not inside the pelvis till the final step. It is mostly extra pelvic, and it is more in the abdomen for the fetus to grow. It is only when it is going to engage the pelvis in the final stages, then only it will be there. So then, depending upon your pelvic inlet views and your CPD angles and the diameters, you can decide whether you need to do a cesarean or go in for a normal delivery. But just to avoid any issues, I tend to remove it, because sometimes most of the patients, or sometimes who are coming far off from my place, and because they are not only from Delhi, they will be from far off areas, and they might be having their deliveries somewhere outside. So to avoid any problems, I remove them in such cases. Interior things.
Thank you very much.
Thank you so much, sir. Finally, I would like to thank our dear speakers, Professor Vivek Trikha from India, Professor Said Abdelhamid from Egypt, for their excellent presentations regarding this very important topic in trauma, which is the pelvic acetabular injuries. Many thanks to the Egyptian Orthopedic Association and the Indian Orthopedic Association. Many thanks to my dear friend, Dr. Srinivas, for his great effort and continuous support in this cooperation, not only in the Egyptian Indian Orthopedic course, but also in the subspecialty courses. Thank you so much, my dear friend. Many thanks to Ortho TV for live streaming these webinars to all over the world countries. And thanks to Eva Pharma Company for sponsoring this course. Many thanks to all of you, and have a nice time, and see you soon. Thank you so much, sir. Thank you so much.
Thank you so much.
Yeah, everybody.
Have a nice time.
Good night.
Thank you.
Good night.
Bye. Bye-bye. Good night.
Good night.